Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our quick sessions in which we summarize together one of the top articles. Today we are going to talk about one of the latest top articles, July 2023, Quantification of Blood Loss in Obstetric Hemorrhage, Implications on Intervention and Transfusion. This talk article, guys, has focused on the different methods to quantify the blood loss and how it's going to affect our protocols for obstetric hemorrhage and how we can update them to be more effective, because hemorrhage is still a global burden to each country, especially the low-income countries. It can reach up 27% of maternal mortality rates, and in the UK, it is the fourth commonest cause of direct maternal death, and it remains the main reason for admission to the intensive care unit for obstetric patients. That's why we are going to discuss the different methods for measurement of blood loss and see if they are effective or not. The first one is the visual method, and the visual method is the most common one. Everyone knows it because it simply depends on your naked eye. You are going to see how much the patient has lost and estimate it approximately. You can also use visual aids that can be displayed in labor or delivery rooms or theater and so on to help you figure out how much your patient lost. This method is very easy and it does not going to cost us anything. However, it is inaccurate. It can lead to poor management, and because of the various of estimation across practitioners, it's not going to tell us even a close estimation for the actual blood loss. And guess what? They have figured out that the level of experience among professionals is not going to affect the error of estimation. So that's why they said there is no difference in the error of estimation between different types of healthcare professionals. The second one would be the gravimetric method. The gravimetric methods depend on assessing the weight difference between the drapes and the swabs you are going to use before and after the operation or labor. Every gram of weight is going to be equivalent to 1 milliliter of blood loss. There is also the volumetric method. The volumetric method is going to weigh how much the patient has lost from the total blood collected with the under-buttock drapes, like this one. It can be calibrated, and sometimes it's not. When it's calibrated, it's going to tell you how much approximately in milliliters the patient has lost. If it's not calibrated, you are going to weigh them. Several studies has shown that combination between the volumetric and gravimetric method can be very effective and really close to the actual volume of blood loss. However, this method needs equipment, it's time consuming, and there's, of course, the risk of contamination. We still have higher volume estimates, and we still can have the risk of underestimation if some fluids are not collected or not the total blood is collected. You can overestimate also the amount of blood because you are collecting the amniotic fluid or urine throughout the process. The next one would be the photometric method. The photometric method, they say that is often used as the standard when comparing the accuracy of other methods. What is photometric method? Photometric method depends on the hemoglobin concentration pre and post-operative, pre and post-delivery. You are going to use the spectrophotometry. Spectrophotometry is going to take time. It takes a preparation, okay? So it's not quick, and it's it really needs some equations to calculate the blood loss or the estimated blood loss. Some of the anesthesiologists can depend on it when they want to calculate the amount of blood allowable during the operation, for example. And there are many websites that have calculators like Omni Calculator, for example, as you can see here. You're going to enter the sex of your patient. Of course, for us, it would be a female, her weight, the initial hemoglobin, and the lowest acceptable hemoglobin. That would be for us like 7. And it's going to calculate the allowable blood loss for you. However, this method is going to take time, and it requires equipment, and it's somehow costly, and it cannot be done in real time, and it requires preoperative hemoglobin, which is not available in most of our cases, especially if your patient is not hospitalized. She came in labor or in the emergency room, and of course, if it came in trauma. Okay, the next one is going to be the calorimetric method, and this one is the latest one. This is the most updated one, and it depends on systems, automated systems, like Triton, and Triton are produced by a surgical company, named Goose Surgical Company, and they utilize iPhone app. This app is going to depend on the amount of hemoglobin inside the gauze you are going to hold in front of them, or the calibrated container that contains the blood. You are going to scan the code that you hold from your facility, and when the app or the program open to you, you are going to insert the patient information and so on, and then you are going to hold the cloth or the drape in front of the camera, or scan the code as here from the container, as you can see, and then the machine is going to calculate for you how much blood is lost. This one is really great, really good. It's like outbreak in the technology, but it's very costly, and not everyone is going to use it, and it's not going to be available in each facility. As you can see, it can even estimate the hemoglobin, and it can estimate the blood loss also. However, it's costly, it's time consuming, it requires equipment, obviously, and again, it requires preoperative hemoglobin. I wish this could be the innovation that can be in each and every facility. Next, the author are talking about some of the methods that is used or can be used to help us know when to go for blood transfusion, when to start blood transfusion, or let's say it in medical terms, what innovations can trigger further investigation and management. The first one is the early warning score. The early warning score alone is unreliable at predicting volume of blood loss. However, it can be important when the hemorrhage is concealed, because it's going to tell you when to go for further investigation. All of us know how to score the maternal early warning observation record. And according to the score, you are going to be alerted that your patient is having internal blood loss. She's not doing well, so you need to arrange for further investigation. The second one is the shock index. And the shock index itself it's not going to tell you if your patient is having blood loss or not. However, we have discovered that when the shock index is above 0.9 in women with postpartum hemorrhage, this is going to increase the risk for blood transfusion, surgical intervention, and admission into the ICU. So you can say that the shock index is a method to assess the risk, or maybe it's a method to alert you again when to interfere, when to ask for help. Yes, but it may possibly reassure you in situations that can affect the blood pressure or heart rate. Like, for example, hypertension, or a patient who just had a fluid resuscitation. Her heart rate is going to be fine. Or the one with systolic blood pressure, her blood pressure is going to be okay while she's having bleeding. So not in every case the shock index is going to be your friend. That's why you cannot depend on it alone. Okay, what about the serial hemoglobin? Can we depend on serial hemoglobin to quantify the blood loss? Most of the studies have shown that hemoglobin measurement during continued postpartum hemorrhage is of little value. Yes, it can show you that there is a decline because of blood loss, but it's not going to give you a good estimate for how much blood loss has happened. Because hemoglobin can be normal at the time of acute hemorrhage, then it's going to have a steep decline in the following 6 hours. And that's what many meta-analysis has shown. And I wish I can show you a recent meta-analysis for the levels of hemoglobin that decline, and when it has this steep decline, it starts like 2 hours postpartum hemorrhage. In the first 2 hours, or from 30 minutes to 2 hours, the patient can have normal or nearly normal hemoglobin. How can we use hemoglobin, or in any way, how can we monitor the hemoglobin for our patient? And can we use the hemoglobin for another reason? Yeah, we can use it when we have a massive obstetric hemorrhage to help manage the continued blood loss replacement. This is when the hemoglobin is useful. We can use the lab hemoglobin estimation, or the lab test, or we can use the HemoQ point of care test. HemoQ point of care test is such amazing tool because it's point of care test, so it's going to be beside the patient. It's very quick. It can give you a reliable hemoglobin result in 45 seconds only, and only from 10 microliters of blood are just going to fill the microcuvette with the patient's blood drop and place it into the analyzer, and voila, you are going to have the estimated hemoglobin, and it's really accurate. Okay, last one is the lactate levels. Can we depend on lactate levels to quantify the blood loss or not? Actually, we still need further studies before we apply to postpartum hemorrhage and transfusion of blood products. However, we have discovered that lactate levels has been raised in postpartum hemorrhage are going to need blood transfusion in a point or another, especially those who are hemodynamically stable. And this is really interesting. Some patients who have lactate more than 2, this could indicate significant hypovolemia. However, again, the point of care test may be falsely reassuring. So we still need repeated testing and ongoing clinical assessment. So in short, can we depend on lactate or not? Lactate alone, no. But when we combine it with the clinical assessment, when we combine it with the trend in the lactate levels, especially for those who are hemodynamically stable, but they are having high lactate levels, this could indicate significant hypovolemia. And that's why, guys, our college always advocates the usage of the combination of clinical assessment plus those modalities. Clinical assessment is the key for correct estimation of blood loss, not alone, of course, with other methods. Okay, the talk article also mentioned something about the thromboelastography. And thromboelastography or thromboelastometry is methods that allow rapid assessment of coagulation using saturated whole blood. How? Those techniques, guys, are going to use the blood and they are going to let the blood clot and then analyze the clot that has been formed. And they are going to give you a graph like the one you are seeing now. According to this graph and according to the readings, we are going to know if this patient extrinsic pathway is working efficiently or not by the R time, by the CT time, and by the clotted strength. This resistance that is measured over time and displayed in this graph has been proved to be reliable in reducing blood loss and transfusion in cardiac surgery. And for us as obstetricians, it has been useful because we have now protocols depending on the raw temp that help us a lot to guide the management of hypofibrinogenemia and thrombocytopenia. When the FIP TEM in the raw TEM system or TEM device, it's going to give you low FF value. This means that you need fibrinogen or cryoprecipitate. And when the R time or the XTEM CT in the raw TEM is prolonged, that means that you need fresh frozen plasma. So it's really helpful. And because we have a raw TEM protocol for the use in postpartum hemorrhage that has been advocated by the OPS KIMRO or CYMRU, Obstetric Bleeding Strategy for Wales. This protocol is really amazing. It depended on the readings from the raw TEM and the defect TEM specifically, the fibrin polymerization. And accordingly, you are going to see if this patient needs fibrinogen or not. And again, with the component of the raw TEM, the XTEM CT, we are going to know if we can use fresh frozen plasma or it's not required. And according to the full blood count and the platelets, we are going to determine if this patient needs platelets or not. Finally, the talk article talked about the obstetric bleeding strategy for Wales, the same pathway that depended on the raw TEM before, has made a beautiful 3 stages protocol for how to manage the postpartum hemorrhage. Stage 0 talk about formal risk assessment for all women admitted to the delivery suite, and you are going to assess both antenatal and perinatal risk factors for postpartum hemorrhage, whether this woman had an active management for third stage or not. Stage 1 is when the blood loss is more than 500 milliliters, and its main purpose is to alert you for the need for further assessment and help to measure blood loss. And whether you are going to give uterine tonics or it reminds you with the steps like emptying the bladder, checking the placenta, if you are going to do a bimanual compression or uterine massage, and so on. Stage 2 activated if the blood loss exceeds 1,000 milliliters. If there are clinical concerns or abnormal vital signs. It's going to prompt more frequent observation, additional intravenous access, and blood tests like the raw temp, lactate, hemoglobin, and so on. Stage 3 is going to be activated if the blood loss is more than 1,500, and it's going to tell you important management steps, including the transfer of the patient to the theater, activation of the massive obstetric hemorrhage protocol, and of course, involvement of obstetric and anesthetic consultants. Those stages, guys, is really beautiful and very helpful. And by revising those stages, we have reached the end of our discussion. I hope it's really easy for you now. The talk is really long. If you're going to read it from the original file in the talk website, I hope it's now easier for you and more clear. Thank you so much for being here today, and see you soon, inshallah. Bye-bye.